Professor Matthias Stuber from Lausanne, who will give a lecture on highly time-efficient imaging strategy, cardiac MR.
Thank you very much, Philippe, for the nice introduction. And I also would like to take the opportunity and thank the organizers for inviting me here. And I probably have to finish in 15 minutes, right? Because otherwise it wouldn't be time efficient. All right, so here are my disclosures, all the known stuff, but another disclosure is I really love MRI, and so therefore I probably have a biased view as well. All right, so now we are all in the business of making sharp images of the heart, right? So you see it here in the background, the image from the left to the right gets sharper. And how are we doing this? Well, the mainstays we are employing is the EKG on the one hand, and then breath holds or navigators on the other hand. And those of you who are familiar with that with that French comic, this is Asterix and Obelix and Idefix the dog, who are holding their breath for a prolonged time. So that would be actually very good for cardiac MRI. But while we are at it, of course, we have to collect a lot of different scout scans here, left, right, etc. And when you think you are done, you are in a short axis, then think again, because then you have to first acquire a 4-chamber view, then perpendicular to it, you finally get to such nice images of the heart at multiple levels, at multiple short axes. And this, of course, requires a lot of mouse clicks, and this makes it highly, highly inefficient. And also you have to think about the repeated breath holds in between all of these scans, which add a lot of time to these protocols. Now, speaking a lot about the mouse clicks, and I've shown this slide already a couple of times, and mind you, this is just anecdotal, this is just one example in our lab, but for a cardiac exam in our lab, we need about 350 whopping mouse clicks, while a brain scan doesn't even take 20. Now, of course, we could do statistics about that and see for the different exam how long it takes, but I think the order of magnitude remains the same, and it's quite telling how much work the cardiac MR exam is, and also here we have to conclude that it's quite inefficient. So what would we like to have in the ideal case? Well, we would have such a scout image, and then we just put a box on the heart, and I think with artificial intelligence this is a no-brainer, so to say. You could do this even automated, and then it would not even take one single mouse click to extract information about the heart, which you then can go and flexibly and retrospectively interrogate for different types of information about the heart, anatomy, function, flow, tissue characteristics, etc., etc. And while we're dreaming up things already, we could also say, well, let's equally get rid of the EKG and of breath holding. Okay, how can we go about this? How can we go in that direction? Well, this concept builds on 3 pillars. The pillar number 1 is a free-running sequence. As you can see here, it's just constantly pulsing regardless of the underlying respiratory or cardiac motion. RF pulses are constantly applied, readouts are constantly performed with this radial golden angle scheme, where every interleaf is rotated by the golden angle on the one hand, and where every interleaf has a SI projection on the other hand, which is shown in red here, to extract the physiological signals. Okay, once you're done with this, and of course because of this golden angle scheme, and if you then tease out different subsets of data as shown here, then you have every single individual case space is rather uniformly sampled, which is a very, very useful characteristic of this approach, which you would never have with the Cartesian technique. So the second pillar that informs this whole idea is total self-navigation. How does this work? Well, you have the case-space acquisition, and in various types or various forms you can extract motion information from case-space. For instance, you can go in the center of case-space, look at that signal, and use that to then look at the frequency spectrum of that, and then you can apply filtering, and you can extract the respiratory and the cardiac motion Right now we have also more sophisticated approaches, and if you're interested in this, you can look at this poster here from Isabel Quesada, which you can go look at in the back of the room, a more sophisticated way of doing essentially the same exact thing. Now you can back transform this into the time domain and extract cardiac and respiratory signals, which can then be used to inform reconstruction. Simultaneously, if you're so inclined or if you have the hardware, you can actually also inject the pilot tone signal into more or less the same exact pipeline to do again the same to inform the reconstruction. Now, how does this work? This reconstruction is informed by these signals in that we have the respiratory and the cardiac signature, which allows us to then dilute these data sets along the time dimension on the one hand and along the respiratory dimension on the other hand. Okay, and once you have this, then because these data sets are heavily undersampled, you need some kind of a smart reconstruction tool, and we have this in the form of this compressed sensing reconstruction engine, where you can see we have both the regularization in both respiratory and cardiac dimension. Once you're doing this, then you realize that you really change the paradigm from a prospective scan plan adjustment and parameter adjustment to a retrospective extraction of information. You can choose the temporal resolution, you can choose the time point of the cardiac cycle in which you want to reconstruct the data. If you're so inclined, you can also go into the respiratory dimension, or you can interrogate the data set and go through space and look at the different reconstructions at the different levels. And here you can now retrospectively tease out all the different orientations that you are looking so carefully for in the 2D exam. Now, this acquisition time is about not quite a quarter of an hour. We dubbed this the free running framework, which builds on the 3 pillars I just mentioned, and which really makes the whole procedure a whole lot easier because you only need a single mouse click. It's highly time efficient because you constantly pulse without interruption, without breath holds, and you don't need to set up EKG electrodes or bellows or navigators, which add another level of inefficiency. Now, I have shown you BSSFP flavor of this framework. I'm showing you also a couple of other ones, and this is hot off the press. You agree with me, certainly these are noisy images, but these were acquired on a 0.55 Tesla system in collaboration with Lon Simonetti at Ohio State University. Xavier Sieber, we sat him in an airplane, we sent him there to collect these data, and this is what came out. No sophisticated denoising is applied yet, but nevertheless, on this system, without EKG, without bellows, without navigators, these images came out right away. So this is very promising, and the acquisition duration was only about 6 minutes. So there is still a lot of leeway, still a lot of opportunity to improve. Moving to gradient echo imaging, these images were acquired with ferumoxytol in pediatric patients. Now our pediatric cardiologist colleague Milan Psa at our institution now regularly acquires data with ferumoxytol in these pediatric patients. Scan time is about 7 minutes, and you can get such images out of this where you can see an anomalous right coronary artery. And I squandered my youth with developing coronary MRA, right? And when I'm looking at this, I was just flabbergasted to realize this is possible without EKG, without breath holds, without navigators, just a free running sequence. And in a small child, you can get to this level of information, and even in a clinical sense. And so what's happening at our institution is that Milan Psa, the cardiologist now, for a certain age bracket of patients, he doesn't even need the patients to undergo general anesthesia anymore, which of course is very, very beneficial for the patient, for the staff, for the parents, for everybody. They only undergo a relatively light sedation, and that's it. Okay, and this was also done in collaboration with the CHOP, with Mark Vogel and Kevin Whithead. Moving on, this is a very nice collaboration with Japan, with Masaki Ishida and Hachime Sakuma, where they very, very carefully optimized the injection protocol, then the scan parameters, and even the reconstruction parameters in order to obtain these images post-gadolinium at 3 Tesla. And this didn't even take 10 minutes to acquire, and again, very, very nice depiction here, in this case of the right coronary artery. And this is a very nice example, I think, of a collaboration between Japan and Switzerland, where we worked together in order to obtain these nice results. Then Augustin Augier yesterday showed you these results here, also at 3 Tesla, here without contrast agent, and he interjected the T2 prep in order to generate the contrast between the myocardium and the blood pool, because without the T2 prep and without contrast agent, you wouldn't have a contrast between the muscle and the blood. You also have to think about that these sequences are non-selective, so you don't have an inflow contrast whatsoever, so other means of generating contrast are required. And this was about 6-minute scans. This is another example, moving to ultra-short echo time imaging. This is data which were acquired by Giulia Rossi in my team. On the left-hand side, you can see the gradient echo variant. On the right-hand side, the UTE version in a 6-month-old patient with severe pulmonary artery stenosis. I put an arrow here so that you can see where this pulmonary stenosis is. And of course, if you use a gradient echo sequence, you can see when the flow is relatively high, you have flow artifacts, and the patency of that vessel can no longer be confirmed on the left-hand side, whereas on the right-hand side with the UT, and thanks to the short echo time, the patency of the vessel, this connection there can always be seen. So the same concept also works for UTE, also in about a scan time of roughly 6 minutes. Increasingly at our institution, this cardiologist here, Tobias Rutz, is now using a FIS technique, FIS, which was originally developed by 2 people here in the room, by Bob Edelman on the one hand and our esteemed chair, John Kokzoglu on the other hand. And we were fortunate enough to enter a collaboration with them and to combine their FIS idea with our free-running framework. We implemented it, and now our cardiologists relatively routinely every week now acquire a couple of patients with this technique post-contrast, because in most patients, contrast agent is on board anyway, and this scan duration is about 5 minutes. And here is one of these publications we did together again with Bob Edelman and John Kokzoglu. Finally, another nice collaboration with people here in the room, with Michael Markle. Michael Markle sent 2 of his students our way, luckily, who then combined their 4D flow ideas with our free-running ideas, and so 5D flow was born as a result. And the interesting aspect of this is, while 4D flow is very powerful, of course, but it requires navigator technology, which on the one hand needs experience to set it up, and on the other hand adds inefficiency because of the respiratory pattern. If you're doing this like here in 5D, the scan time is always constant, no physiological parameter affects scan time anymore, and you can get out these data in about 8 minutes. And here is one of the papers we were fortunate enough to write together. Now, coming to the end, I hope I was able to demonstrate that this is a highly efficient approach for scanning, where the MRI scanner is actually used for scanning and not for planning, not for setting up electrodes, not for orienting the slides ever so slightly. No, it's really used for scanning. And it's highly operator independent, because you only need to plan a box, single mouse click, the scan starts. And of course, this advances the hypothesis that operator dependency is heavily reduced, and interscan reproducibility would be much, much better, and you would always gain to get the same results on multiple scanners at multiple sites as a result of that, because you don't need to futz around with the parameters anymore. But finally, and I have 4 seconds. The time it uses for the offline reconstruction is still relatively heavy because we only run it on MATLAB, but I'm very, very optimistic that in the future on C++ implementations with AI and the computers getting faster and faster, this will be done inline on the scanner in the next future. And with that, I would like to thank you for your attention, and also my team for contributing. If I can show the last slide. No, it's gone.